Hi everyone, my presentation today will focus on anticholinergic bronchodilators and how they are used in treating asthma and COPD. My group's main topic is on beta-2 adrenergic agonist, but I was very interested in another method and how we take advantage of neurocommunication to treat breathing problems. With introduction out of the way, let's get into it. To begin this discussion, we will be going over a general understanding on the purpose of anticholinergic bronchodilators in treating breathing problems in patients with asthma and COPD. Next, we will discuss the biochemistry and metabolism of acetylcholine and its importance in helping developing a treatment option. And finally, we will look at a few current medications and their known mode of action, structure-activity relationship, stereochemistry, physiochemical, and pharmacokinetic properties. Any other interesting discoveries during the research will also be relayed towards the end of the presentation. What are anticholinergic bronchodilators? Simply put, these are drugs used to treating breathing problems in patients with asthma and COPD. For instance, during asthma, cholinergic nerves that go towards the lungs cause the airways to constrict, which is stimulated by surrounding airways to contract. The treatment plan in this case would be to block the effect of acetylcholine on the airways and nasal passages, which blocks the effect of cholinergic nerves and causes the muscles to relax and airways to dilate. This would in turn help the patient improve his or her breathing problems. The image here shows an example of this type of drug. Here we have ipratropium bromide, an example in this class of bronchodilators that has a relatively low percentage of bioavailability and short duration of action. Before continuing, I'd like to point out some important information. Acetylcholine is the endogenous neurotransmitter of the parasympathetic nervous system. These parasympathetic nerve fibers are found in the autonomic and central nervous system, which contains muscarinic receptors, which is just a type of acetylcholine receptor that forms G protein coupled receptor complexes in the cell membranes. We are interested in these muscarinic receptors found on the parasympathetic postganglionic nerve endings. Hence, we want drugs that block the muscarinic fiber, which results in bronchodilatory effects. As a side note, although blocking the muscarinic fiber does have bronchodilatory effect, there are also cardiovascular, mediatric, antispasmodic, and anti-secretory effects that could result. This, in general, appears as a great medication in treating variations of health complication, but it also relates to the importance of treating the specific problem and not causing other unwanted effects. As stated before, acetylcholine is the endogenous neurotransmitter that is involved in bronchoconstriction via the muscarinic receptor. Acetylcholine is a product of choline, acetylcoenzyme A, via acetyltransferase enzyme. The choline used in the reaction is produced from a transferase enzyme that converts ethanolamine to choline, or a recycled product of a later reaction in the process that results in bronchoconstriction. The recycled choline in the figure occurs when the acetylcholine formed undergoes a hydrolysis reaction of acetylcholinesterase on the postsynaptic terminals in the synaptic space. The formation of acetylcholine occurs on the presynaptic cholinergic neurons. After acetylcholine is formed, it is stored in the presynaptic vesicles and released during stimulation. When metabolized, acetylcholine has a short duration of action due to the rapid hydrolysis reaction via acetylcholinesterase enzyme on the postsynaptic terminals in the synaptic space. The hydrolysis reaction splits acetylcholine into acetic acid and choline. There are two different hydrolysis reaction steps that result in products formed. Step 1 of the hydrolysis reaction results in the nucleophilic attack of the carbonyl carbon of acetylcholine by the serine residue of the acetylcholine esterase enzyme. The hydrolysis reaction results in the production of the choline, and the serine residue becomes acetylated. Step 2 of the hydrolysis reaction hydrolyzes the acetylated serine residue. In this reaction, a nucleophilic water attacks the electrophilic carbonyl of the acetylated serine residue to form acetic acid and regenerate the free hydroxyl group of the serine. So as you can see, the figure on the left shows the binding of acetylcholine to the catalytic site of the acetylcholine esterase enzyme. The N group is bound to tyrosine, glutamine, and tryptophan, while the carbonyl end undergoes a nucleophilic attack by the serine hydroxyl group. The nucleophilic attack by the serine residue is caused by the catalytic triad between glutamine, histidine, and tryptophan, which activates the serine for the nucleophilic attack. The nucleophilic attack is also depicted in the figure on the right, which relates to the role of the catalytic triad in the hydrolysis of acetylcholine. You can see how the triad stimulates the nucleophilic attack on the carbonyl carbon of acetylcholine, which results in the first hydrolysis reaction. The oxygen of the choline end attacks the hydrogen bound to the charged nitrogen group, resulting in the formation of choline. Continuing in the reaction pathway, the acetylated serine enzyme is hydrolyzed to regenerate the free enzyme group. As stated in the previous slide, this is the second hydrolysis reaction. The specific hydrolysis step occurs when water is bound to the histidine residue, which increases the nucleophilic capability of the oxygen in the water. The nucleophilic water attacks the carbonyl carbon on the acetylated serine to free the serine group and form an acetic acid. Finally, we are left with the products of the reaction, choline and acetic acid. The muscarinic receptors are membranes of the G protein coupled receptor. These receptors are found in the smooth muscles, secretory cells, and certain central synapses. This explains why cardiovascular, mediatric, antispasmodic, and anti-secretory effects are related to the receptor. There are 5 receptor subtypes, M1 to M5. These subtypes are categorized into odd numbers, M1, M3, M5, and even numbers, M2, M4. This categorization is based on the differences in intracellular responses. For the purpose of this discussion, the M3 receptor is responsible for bronchoconstriction. This counterbalances the bronchodilation mediated by beta-2 adrenergic receptors in the lung to maintain bronchial tone. In addition, the M3 receptor is also responsible for contraction of the iris circular muscle, GI tract smooth muscle contraction, increased secretion, and other numerous physiological actions of the parasympathetic system. Now that we're done with the natural process of acetylcholine and its effects on bronchoconstriction, we can now relate how anti-muscarinic drugs work to alleviate this issue. The key drugs in this discussion are ipratropium, tiotropium, and aclidinium. But before that, we'll be looking at some important features that antimuscarinic drugs share. Since M3 receptors are responsible for bronchoconstriction, antimuscarinics are used to target the receptor. This forms the basis of the use of inhaled muscarinics to block cholinergic bronchial constriction and allow adrenergic bronchodilation to overcome pulmonary constriction. Antimuscarinics bind to the M3 receptor in the same manner as acetylcholine, but they contain additional hydrophobic substituents. In comparison, we have the image of the endogenous neurotransmitter, acetylcholine, occupying the hydrophobic pocket. These additional substituents bind to the hydrophobic pocket in the receptor, which prevents the conformational change required for the intake of the agonist to intracellular G protein. The signaling pathway becomes unattainable, which leads to the inhibition of bronchoconstriction. As stated earlier, this would allow adrenergic bronchodilation to overcome pulmonary constriction associated with asthma and COPD attack. Another feature of antimuscarinic agents is that the pharmacophore of all antimuscarinic drugs is an acetylcholine analog in which the acetyl methyl group is substituted with at least one phenyl ring. For better understanding, pharmacophore is a segment of a molecular structure which is whether it is native to the body or from a drug that participates in biological or pharmacological interaction. The pharmacophore for antimuscarinics is classified as an amino alcohol ester. This is the segment of acetylcholine responsible for the biological response in the body. As you can see, this is the portion boxed in the middle figure. The ester functional group can be replaced with different groups to form different classes. When the ester functional group is replaced with a saturated carbon, where R1 is hydroxyl or amino group, this results in an amino alcohol or an amino amide. This is represented by the figure on the far left. The figure on the far right depicts the replacement of ester with the ether functional group. The class would be classified as an amino alcohol ether. Something else to note is that since nitrogen is the primary point of the receptor interaction, it must be in a quaternary form or be cationic at physiological pH. However, the quaternary structure of nitrogen is not completely required to create the antagonist effect of antimuscarinics. Since drugs like a T-butyl will still present the minimal requirement for activity to take place. Atropine is a classical prototype of antimuscarinics. The structure is an amino alcohol ester pharmacophore, in which R1 is the hydroxyl methyl group, R2 is hydrogen, and the nitrogen is part of a bicyclic ring system called tropin. As noted previously, the pharmacophore is the basic form responsible for pharmacological interaction. The tertiary and quaternary form of nitrogen is the most active for the muscarinic receptor. In the case of atropine, the tertiary amine is protonated at physiological pH, allowing it to bind to the anionic aspartic acid of muscarinic receptors. When nitrogen is modified to a quaternary form, oral bioavailability is lost, but also leads to compounds that can be administered effectively by inhalation. The first of the three medications is ipratropium hydrobromide, or brand name Atrovent. It is the N-isopropyl analog of atropine. Because of its quaternary cationic nature, making it highly hydrophilic and poorly absorbed from the lungs after inhalation, the bronchodilation effect is considered a local site-specific therapeutic effect. Much of an inhaled dose is swallowed and excreted without any significant absorption. And any of the little amount that does reach the systemic circulation is minimally protein bound and metabolized to its inactive form. The medication is indicated for bronchospasms associated with COPD. The inhaled form of ipratropium has a 15-minute onset of action and a relatively short duration of action of about 6 to 8 hours. This is the basis of why it is dosed 4 times a day. Other drugs, including adrenergic agonists, methylxanthines, steroids, cromolene sodium, can be co-administered with ipratropium in COPD without any adverse drug-drug interactions. For instance, beta agonists are used to help patients with breathing problems. I mentioned earlier that antimuscarinics can indirectly aid the beta agonist in improved breathing. Therefore, this co-administration can increase the effectiveness of treating patients with COPD. Side effect of this drug includes blurred vision, dry mouth, tachycardia, urinary difficulty, and headache. Tiotropium is the alpha-alpha diethylene derivative of N-methylscopolamine, which is a quaternary analog of naturally occurring scopolamine. Interestingly enough, scopolamine is commonly used to treat nausea and vomiting caused by motion sickness, intestinal problems, muscle spasms, and Parkinson-like conditions. This differs from ipratropium, which is the analog of atropine. Tiotropium is indicated for bronchospasms associated with COPD and considered a site-specific local medication to the lung when inhaled. The system distribution of tiotropium is similar to ipratropium because oral inhalation is minimal due to hydrophilic character. It is metabolized by CYP3A4 and CYP2D6 enzymes, and glutathione conjugation is result in various metabolites. Only the small amount that reaches the systemic circulation is hydrolyzed to the inactive metabolite. Common side effects of using tiotropium include dry mouth, blurred vision, tachycardia, urinary difficulty, and headache precipitation. The last part of the 3 medications is aclidinium bromide, or brand name Tudorza. The active compound is structurally related to tiotropium in that it is an alpha-alpha diethylene substituted quaternary amine, with the N-methylscopolamine moiety is replaced by an N-phenylpropyl 1-azabicyclooctane ring system. It has a kinetic selectivity for the M3 over the M2 muscarinic receptors. Aclidinium is a long-lasting bronchodilator with a quick onset of action. The maintenance dose is 1 puff 2 times a day, about 12 hours apart. It is rapidly hydrolyzed to its inactive form and has a very short half-life, leading to lower possibility of antimuscarinic side effects. In a clinical trial with patients with mild to severe COPD, patients were treated with aclidinium, which produced sustained bronchodilation over 24 hours with no side effect related to the treatment. This table compares the previous 3 medications discussed. It compares them based on their bioavailability in the systemic circulation, onset of action, duration of action. Ipratropium has the lowest bioavailability and the least onset and duration of action. Tiotropium and aclidinium have longer duration of action, but they differ in their onset of action. These differences are important for setting different treatment regimens based on the patient's need for a short-acting inhaler and a long-acting inhaler, or probably using both. To end this presentation, I thought it would be helpful to tie my topic on antimuscarinics to my group's main discussion on beta adrenergic agonist in treating COPD. The data conclusions come from a literature published by Dr. Shelley R. Salpeter that summarizes the long-term clinical outcomes associated with beta agonist and anticholinergic bronchodilator used in patients with COPD. These are pooled data from the randomized placebo-controlled trials of at least 3 months at least 3 month duration to evaluate the risk of COPD, hospitalizations, respiratory mortality, and total mortality. When anticholinergics were compared with placebo, the data results showed it reduced the risk of COPD, hospitalization by 30%, and deaths by 70%. Long-acting tiotropium was compared against short-acting ipratropium, and the results showed tiotropium to have less severe exacerbations than ipratropium. When comparing beta agonists with placebo, the compiled results revealed beta agonists to increase respiratory deaths by over twofold compared to placebo. For both anticholinergics and beta agonists, it was also estimated that about 58 and 56%, respectively, of the patients were on concomitant inhaled corticosteroids. Finally, data comparing beta agonists against anticholinergics revealed that beta agonists increased risk of hospitalization and total mortality when compared with anticholinergic use, and that both combinations of anticholinergic and beta agonist results found that the combination was no better than anticholinergic use alone on these long-term clinical outcomes or quality of life. In addition, more studies are needed to evaluate the long-term clinical benefit of the long-acting beta agonist, salmeterol and formoterol, in combination with inhaled corticosteroids, compared with the long-acting anticholinergic agent tiotropium, combined with inhaled corticosteroids.